the hole in time. Okay, now I invite Dr. Prakash sir to give his talk on surgical management and decision making in endophthalmitis. Dr. Prakash is a HOD and Chief Retinal Surgeon at Comtrust Eye Hospital, Calicut.
Thank you, Divya, for this opportunity. So my talk is tackling the nightmare, that is decision making in endophthalmitis, postoperative endophthalmitis. So as we all know, postoperative endophthalmitis is defined as an inflammatory condition of the eye, presumed due to infectious process from bacteria, fungi, or rare occasions parasites that enter the eye during the perioperative period. So when do you suspect this dreaded complication? First postoperative day, we usually you don't get an endophthalmitis. Most of the time it is a task. But if you have a hypopyon on the first postoperative day itself, then you have to have a high index of suspicion of endophthalmitis. After the first day, any worsening of AC cells by 2 steps or presence of a fibrin, then you should always suspect endophthalmitis. If you should remember that in 15% of the cases in EVS study did not have hypopyon. And again, one more common pitfall is waiting for vitreous inflammation to begin to diagnose endophthalmitis, because it starts in the anterior chamber, so you have to look at the anterior chamber, and if you see inflammation, it is better to err on the side of diagnosing endophthalmitis rather than missing an endophthalmitis. So from where do these organisms get in? Usually from the patient's own surface flora, that is a sporadic endophthalmitis, or it is from the surgical instruments or fluid or tubing that is seen usually in cluster endophthalmitis. And most common organism in Indian studies has been coagulase negative staphylococcus, that is Staph epidermidis mainly. And acute endophthalmitis is defined as either fulminant endophthalmitis when it happens within 4 days of the surgery. Usually it is gram-negative organism. Usually Pseudomonas is the most common organism that causes this. Or it is called acute, which is about 5 to 7 days after the surgery. Or subacute when it happens 2 weeks to few months, usually seen by P. acne or caused by P. acne or Staph epidermidis. Or it can be chronic when it is either fungal. It is usually seen with cases like trabeculectomy, post-trabeculectomy or post-SFIOL, chronic cases. So it has to, because all these cases have a good potential to be a medico-legal case, you have to properly do the documentation of these cases, and all examination findings has to be well noted down. So B-scan is one of the, if you have a good fundus view, which is very rare in these cases, you should do a good thorough indirect ophthalmoscopy and note all the findings. You may have retained lens matter, retained dropped intraocular lens. All this has to be visualized and documented, but most of the time we don't have good posterior segment view. So B-scan is the most essential tool for assessment of pre-op assessment of these cases. And I want to add a word of caution. It is not, B-scan is not used for diagnosis of endophthalmitis. Diagnosis of endophthalmitis is always clinical. B-scan, for example, in an early endophthalmitis, when especially due to gram-negative organisms, there may be a liquefactive necrosis of the vitreous. So you may not see, B-scan may be totally echo-free. So an echo-free B-scan does not rule out an endophthalmitis. So please don't use B-scan for diagnosis of endophthalmitis, but it is very useful for diagnosing associated conditions like retinal detachment, or if there is a panophthalmitis. You can see in this case, you can see there is a large choroidal detachment with suprachoroidal abscess here. So this helps you in surgical planning. How do you put your instruments in these cases? So this is very useful in these cases, and also you can see the posterior suprachoroidal fluid here, which is suggestive of panophthalmitis, and this patient needs evisceration. So that's the role of B-scan in evaluating these cases. Once you have confirmed your diagnosis and immediately you have to form a management plan. And it's always an emergency to tackle endophthalmitis, and you have to give intravitreal antibiotic at the earliest and get a sample for microbiologic assessment at the earliest. So what is the best sample? So the best sample is always a vitreous sample. All studies have shown vitreous to be the best sample. So you can either go for a vitreous tap with a needle tap with a 22-26 gauge needle, or you can go for a vitreous biopsy where you use a cutter to take 0.2 to 0.5 ml of fluid from the undiluted specimen from the vitreous cavity. And most of the studies have shown that the vitrectomy fluid that you get from the cassette after the end of vitrectomy surgery has the biggest yield of organism, and vitreous tap has slightly lesser than that, and AC tap has the least. But if you don't get anything, if you are getting a dry tap and you don't have access to a vitreous tap, vitreous biopsy, then at least do an AC tap. So this is very, very important medico-legally as well as to prevent further endophthalmitis in your setting. And the best plating method is immediately you transport time of the specimen to the lab should be the least so that you don't lose the organism. So as much as possible do direct plating, and you should have one liquid media at least and inject the fluid into the liquid media. Thioglycolate broth is good enough. And one specimen always, because we know all, starting from EVA study, most of the studies show that only 60 to 70% of the cases you get microbiologic yield in these cases. So one specimen has to be freezed for PCR. That is, if your microbiology turns out negative, then you can always rely on your PCR to get to know the organism. It's very, very important to prevent, not only to treat that particular case, to prevent further occurrences of endophthalmitis in your hospital. It's very important you have a microbiology specimen. And intravitreal antibiotics has to be given at the time of TAP or at the end of vitrectomy. So the choice of your organism is, if it is gram positive you are suspecting, you can go for Vanco, or if you are suspecting gram negative, especially Pseudomonas and all, better to go for the newer antibiotics like imipenem or meropenem or piperacillin and tazobactam. And if you are suspecting fungal, go for voriconazole, and if you are suspecting anaerobic organism, go for clindamycin. Intravitreal steroids, it's very, very important to give intravitreal steroids if you rule out fungal. In case of fungal, if you are suspecting, don't give intravitreal steroids. But most of the time, the ocular damage is not done by the organism itself, but by the cytotoxins produced by the organism. So that's it causes an inflammatory cascade inside the eye, which causes the damage to the organism, to the eyeball. So that is why the most important role for giving intravitreal steroid, you can give either dexamethasone, even you can give triamcinolone also. So vitrectomy has a very, very important role in managing endophthalmitis, and your decision to do vitrectomy is when it is a very fulminant endophthalmitis, because these cases have large amount of endotoxins released by the organism, and just tackling the organism, just killing the organism with antibiotic alone is not enough to control the inflammation. So you have to remove as much as possible the bulk of the organism as well as the exotoxin. Also vitrectomy helps you to remove the opacities that's already there. There will be membranes, there will be collection of inflammatory material over the macula, which can be washed off and reduce the macular toxicity. And also it helps you to assess the retina during the surgery, so that will tell you what is happening onto the retina. And also it will increase the yield of microbiology specimen you can get. And the only disadvantage is you need the surgeon as well as you need the instrumentation. And another disadvantage is vitrectomized eye have a more rapid clearance of intravitreal antibiotic. Very often, once the inflammation is controlled, many times you have to do a late vitrectomy to clear, just to clear the media. That is totally different from this vitrectomy. So coming to the surgical challenges and surgical steps involved in vitrectomy, the main problem is to get your infusion cannula inside and to visualize the infusion cannula. Because of the lot of material in the anterior chamber as well as in the vitreous cavity, you won't be able to visualize your cannula. So you can put the AC maintainer through a side port and form the AC, and from the other side you can put your cutter or other instrument and clear the anterior chamber before you proceed with vitrectomy. It's always remember, before you start your open your infusion cannula, get an undiluted sample for microbiologic evaluation. So this is another technique. I'll just take 1 minute, Divya. So this is another technique where you can use a 5 cannula technique, where you put 2 cannulas at the limbus and 3 cannulas in the pars plana. So this 1 cannula you can use for infusion, and the other cannula can be used to clear the anterior chamber. So coming to the next most important thing is to clear the anterior chamber. There will be lot of material. Usually you see this thick material which is plastered over the IOL as well as the iris surface, and also it will be extending to the ankle. So this has to be cleared meticulously. Usually it comes off as a single sheet, and it has to be cleared completely before you go inside and start your vitrectomy. So once you clear this complete material, then I don't have the control over here, I think. So the material is removed with the cutter and the anterior chamber is thoroughly cleared. Can I have the control here? The control is in the scrolling. Okay, leave it, no problem. So the controversies associated with vitrectomy. I'll come to the controversies. The classical teaching always has been to do a core vitrectomy. in all these cases. The aim is to clear the vitreous just enough to see the discant macula. Once the discant macula is seen, you usually stop vitrectomy, because even if you induce PVD and go for a thorough vitrectomy, you might cause retinal tears, iatrogenic breaks, and a retinal detachment is difficult to manage along with an endophthalmitis. So usually you do a core vitrectomy. But there are other people who believe a complete vitrectomy helps in clearing most of the material. This is actually a traumatic endophthalmitis, what the video you are seeing here. So it is very important to secure your section also before you start off with the vitrectomy. So the corneal suturing was done, the anterior chamber was cleared, and in traumatic endophthalmitis, the advantage of doing a thorough vitrectomy is that you might remove all the vegetative matter or any other foreign body that may be inside the vitreous cavity. So you get a better clearance of the inflammatory material, toxin, everything, and also you can treat any peripheral retinal lesions that may be present in these eyes, because trauma may be associated with retinal trias other than that due to the endophthalmitis. So after clearing everything, a thorough fluid air exchange is done, and the peripheral lesions, wherever you feel the retina is necrotic or wherever you feel you have touched the retina, those areas are all lasered, and finally you can put silicone oil. So silicone oil has another advantage. It has got an antimicrobial property, and some people have reported, especially in traumatic cases, they have reported good visual outcome of primary use of silicone oil. And coming to surgical consideration, another thing is to remove the IOL. This is not done in the first episode of acute endophthalmitis, but many cases this may have to be done, especially in chronic low-grade endophthalmitis. This is because especially the organisms like staph epidermidis, they form a glycocalyx on the plastic surface of the IOL, and this protects the organism from the host immune response, both genetically and physically. The organism multiply inside this glycocalyx and shed in between, causing recurrent inflammation. You can see, even though the vitreous is clear, there was a lot of material, whitish material in the anterior chamber. So these cases require IOL removal. Not only IOL, all the capsular bag, all the material inside the anterior chamber. Sometimes there may be membranes in the, you can see there is a thick sheet of membrane here, which has to be carefully removed before you close the eye. So and another controversial area is antibiotic after post-planar vitrectomy, because we usually give 48 to 72 hours repetition of antibiotics, but in vitrectomized eye, the half-life of antibiotics is drastically reduced. So you may have to give post-vitrectomy, if there is any injection, you have to give mostly daily. So to conclude, endophthalmitis is an emergency procedure which requires aggressive management and round the clock monitoring of the patient. Early vitrectomy wherever it is fulminant, especially suggested by poor vision or the amount of exudates and other inflammatory material inside the eye, you may have to do an early vitrectomy. And also it is very important to get a microbiologic specimen before you, so that you can prevent further occurrences of this in your hospital. So, and surgical decision making depend on the type of infection. As I told, in chronic infection you may have to remove IOL. In traumatic cases you may have to go for a more complete vitrectomy and silicone oil. Thank you.
Thank you very much.